Do you ever feel like your mood, sleep, or energy are all over the place, and you can't quite figure out why? In today's episode, Dr. Maria Sophocles helps us unpack the emotional chaos of perimenopause and how these changes can quietly shape our relationships, our confidence, and sense of self. You'll walk away with compassion, clarity, and steps to feel more like yourself again. So stay tuned. Welcome to Fulfillment Therapy. I'm Kendra Nielsen, wife, mom, and licensed therapist. Do you ever feel like you're doing everything right, but you're still exhausted and empty? Did you think life, marriage, and parenting would be simpler and more rewarding? Sometimes you just want to crawl back into bed and lose yourself in screen time and chocolate, rather than face that personal or family stress. You are not alone. This podcast helps you break free of the rat race and build a richer, more meaningful life, flourishing incrementally and realistically, improving your mental health and wellness, and living with deeper purpose beyond the mundane, no matter where you are in life's journey. Welcome back to Fulfillment Therapy. Today we have a special guest here with us, Maria Sophocles. She's a gynecologist, author, and public advocate for women's health. Her mission is to close the gendered healthcare gap, inspired her viral TED Talk and her forthcoming book, The Bedroom Gap, about what happens in sex to midlife. She worked on the creation legislation providing access to contraception in New Jersey, and her Princeton clinic and virtual practice serves 30,000 women in U.S. and globally. She is currently working on a documentary about sex and menopause called Hot, and she's married with 4 grown children. So thank you so much for coming on the show, Maria.
Thank you, Kendra, for having me. It is great to be here. I'm looking forward to talking with you today.
This is something I've been really excited about, and honestly, I don't know a lot about it. I've had some podcasts on talking about parts of it, but not this specifically, and I can't wait to hear what you have to tell us about perimenopause, but also hormones, like I just mentioned, closing that gendered healthcare gap, those types of things. So if you wouldn't mind just telling us how you arrived where you are today, why this is your specialty.
Yeah, so I have been for 30 years a board-certified OBGYN and did the whole baby delivering, doing surgery thing for many years. But then as my patients aged, they had different needs and different questions. They stopped asking about needing birth control and started asking about why they were feeling so disconnected from their body, from their family, from their long-term partner, why they didn't feel right in their own bodies. And these were questions I never got trained to answer. I'm not a trained psychotherapist. I don't have health coaching in my background, although I think now all doctors should have both of those things. And I felt woefully unprepared to really serve them and help them. And they didn't have anywhere else to go. So I got very informed about menopause and perimenopause. This was maybe 20 years ago, and opened one of New Jersey's first GYN clinics really devoted to menopause and perimenopause. And all that was great. But I noticed that the sexual issues were continuing to be a source of shame and embarrassment, as were a lot of the behavioral health changes. People would come in and they would say, I'm anxious for no reason. I tear up easily. My life is crazy busy. I'm caring for older parents. I'm caring for growing children. They were in this sandwich generation that we talk about, and they didn't feel like they had control of their life. They did not feel fulfilled at all. They weren't feeling fulfilled at work because a lot of the perimenopausal symptoms they were experiencing were making them struggle at work with feeling knowledgeable and secure. Things like anxiety, depression, mood changes, word recall, difficulty recalling names or words. These things sound silly, or maybe not silly, but they sound like maybe someone who has dementia. And patients would come in and say, do you think I have Alzheimer's? I literally can't remember the names of the products we sell in my office. I can't remember the name of the new assistant who's been working there for 2 weeks now. They were mortified and shamed. And I found that was, as a doctor, harder even to help them with. If I can help someone with an infection or a cancer, I know what to do. But I myself didn't feel very able to even understand what was going on. That's how my journey developed into becoming a menopause expert, but also to learning a lot more about sexual function in women and the roles we play and the forces that shape how we think as women about what we're supposed to be sexually in our 20s, 30s, 40s, 50s, 60s, 70s, and how that's even changing today. The fact that we have, for example, porn is ubiquitous and people have access to it earlier means more young people learn sexual messages from porn earlier. The fact that we now have online dating has changed the whole dating landscape for people of all ages. And again, I had to learn how to talk to younger women about these things, but also about women in perimenopause and menopause who would say, hey, I'm newly single or I'm widowed or I'm divorced and I don't really know who I'm supposed to be sexually. And I've never even enjoyed sex. What does that even look like? So crazy things like that came into my office, challenges for me clinically. And that's really what forced me actually to have to up my game and really examine menopause in America, perimenopause, learning about the gendered healthcare gap, the fact that we have 30-something testosterone products for men. We have many things on the market easily available and affordable for erectile dysfunction, but we don't have much at all for women when it comes to their sexual health. We don't even have FDA-approved testosterone. It's not approved for women, only for men. So, in lifting the lid on all this, it was like I uncovered this treasure chest of inequity, gender inequity, and of a sociocultural examination of our society and how it's not necessarily serving women and leaving women feeling uninformed about menopause and perimenopause and shamed about their own mental health and sexual health issues that might be there as young women but seem to get worse in midlife. So the book, The Bedroom Gap, there's the book. It deals with all of that. It looks at sex today and menopause today, and it looks at the forces that shape who we are. Why do we fake orgasms, for example? Where did that start? Why is there an orgasm gap at all? What do we do? How do you have sex after infidelity? How do you have sex after chronic illness? And how, most importantly, can you, wherever you are in your journey as a human, how can you find fulfillment for yourself, both sexually and in life? How can you embrace menopause and perimenopause almost as a reset rather than some doom and gloom period? So it's a lot in there. And I'm sorry, that was a long answer, but that should give you a lot to go on.
No, that very much helps breaking that down a little bit for us and what that means and what this book is all about, specifically about sex, about menopause. And I didn't even realize that part you said about, I'm sure most people didn't, about how few products there are out there for women when it comes to hormones and there is for men and why that might be. Actually, I wouldn't mind hearing your perspective. Why do you think that is?
I think our biopharma, biotech, and FDA system, these big entities have been for decades male-owned, run, controlled, funded, financed. And I think because of that, frankly, not to crap on men, to defend men, the idea of having medications and treatments specific for women's health was literally not on their radar. That sounds hard to believe, right? Because we make up 50% of the population. But if you look at the budget for the NIH, it's $47 billion. Only 8% of the budget goes for women and children. They just lump us all together. And even that says something, doesn't it? That we're the species with the uterus, as opposed to, no, we should have equal footing and funding as men. We're half the population. So
Right.
I think if you just take that data, that statistic, that should tell you something. If you look at the consulting firm McKinsey did a study looking at the healthcare gap, what's spent on research for women, what's spent on developing meds for women, what's spent on treating women-only diseases or women-different diseases. The gap globally is over $1 trillion. So it's not like just me coming up with this idea, and this is well known and well supported. And luckily, there are a lot of initiatives now out there, a lot more funding for women, for startups, for women's health products, for sexual health products. So the door is opening, the funding is coming, but we have a long way to go. So that's what kind of gets my ire up a little bit when men can go get Viagra literally online in 2 minutes or from a doctor easily. And women who have sexual issues are told maybe you should have wine before you have sex, or maybe you're just tired, or do you think you might have depression? These are cop-out answers that get a patient out the door. And I think our medical training is another place I have a little bit of a beef, Kendra. I was not trained, and none of my colleagues were trained in sexual health as a part of health. So doctors don't ask about it. So patients don't feel they can ask about it. And with the advent of Viagra, men finally got a little window to be able to ask about it, but women haven't really gotten that permission yet.
Absolutely.
So 69% of all of women have never spoken to a doctor or any clinician about anything sexual. It's just socioculturally not done. So we continue to suffer in silence, and so much is treatable, right? If you have sexual pain and your friend or mom or whatever is in her 50s, 60s, 70s, it's very likely that sexual pain is just from vaginal dryness because there's not enough estrogen in the vagina. Vaginal estrogen is safe for all women. There's nobody it's contraindicated for. It's available. It's not expensive, but you have to literally go find a doctor and beg for it. That's crazy. You don't have to beg for an antibiotic.
Right.
So I think a lot of these problems we can have fulfillment. We just need to advocate for ourselves and know what's out there, and know that your clinician might mean, but they might be embarrassed to talk about it and they didn't get training about it. So you might have to be the one to break the ice.
We find the same things in therapy. Maybe we don't have this extensive training, and it's something that is so important, like you said, to fulfillment, to relationships, all of these things. Like hormones, sex, all of this very much impacts your connection with other people. So I'm glad you're speaking about something that I also don't know nearly as much about. And you're seeing this gap, you're seeing this need of your clients. And okay, what can I do to be informed, learn more, close that gap? So very much appreciate that you're doing that work and that you can tell us a little bit about what you find, like you are right now. Can you break down for those of us that are not as educated when it comes to those next stages for a lot of listeners, especially perimenopause, maybe even menopause, but specifically perimenopause, what that looks like, how it shows up, and what do we do when we feel off?
Absolutely. So let's do a quick definition tour, right? So menopause is when our ovaries are no longer functioning and making estrogen, progesterone, and testosterone. This happens in the U.S. around age 51. And so women live about a third of their life in a menopausal state, a state without ovarian, estrogen, progesterone, testosterone. And I mention all three because you need all three for different functions. Perimenopause is the decade or so that comes before that 51-year-old kind of event. So anytime from late 30s to early 40s to mid or late 40s, women begin to experience not a lack of hormones, but a chaotic secretion of it. So if you go through puberty at 12, from 12 to say 35 or 12 to 40, you have a very predictable cycle. Every month, the estrogen rises in the beginning of the cycle, and then the progesterone rises at the second half of the cycle, and then everything drops and you have a period, or you don't have a period and you're pregnant. This is quite predictable for most women. But as perimenopause begins, the ovaries are aging and the number of eggs are decreasing. And so we don't have the ability to make hormones in the same predictable way as well. We start stumbling. Think about a new driver in the stick shift car on a hill, right? They're not getting the rhythm of the clutch and the gear and all that, and they're stumbling. And that's what happens to the ovaries in perimenopause. And this shows up as irregular periods. Our periods get out of whack, mood changes big time, like worsening PMS. If you have ADD, that can worsen. If you have underlying mood disorders, they can worsen because the brain really needs those ovarian hormones to be predictable. When they're not, the poor brain gets mixed messages and it can really impact mood. We also get so many other symptoms, and I could go on about those symptoms, but the important thing is for women to realize that perimenopause in some ways is much harder than menopause because it's much less predictable. Your perimenopause journey might be different than your friends or your sisters. And nobody has a sign on their forehead saying Kendra's perimenopause is going to last exactly 8 months. So I have no idea when it's going to begin for you or end for you. Some women, it's literally a 1 month thing or a year thing or whatever. And others, it's a decade. And the really awful part is that women in perimenopause are very often dismissed. They say, Kendra, you look too young to be having perimenopausal symptoms. And that's for like older women. So it can't be you. It can be. And I've had women in their 20s and 30s who sadly were destined to become menopausal by 40. And so by 25 to 40, they began having these issues. So it's very important especially if periods are really irregular, to find a clinician who understands that you could be perimenopausal and can help you with the symptoms and help you understand what's behind it. Is it your thyroid? Is it perimenopause, which is the ovaries? Is it an autoimmune disorder? Do not be dismissed. If you feel something's not right and you're being dismissed by a clinician, it could be that clinician's just not equipped to help you, and just be polite, say thank you, and go find another clinician.
Maria, I'm glad that you're speaking to some of these things because I have so many clients that come and talk to me about this. I have thought a lot about this, and it can mimic so many other things, like you mentioned already. Yes. Like, for example, anxiety, depression. Okay, is this a mental health issue? Or is this burnout? You need something in your life to liven it up again. Or is this overtraining at the gym? Like, this could be so many different things. And so getting feedback from different sources. Actually, the reason I said that was I was just looking up overtraining last night. I love to exercise, love to do all those things. But I'm like, I have been so fatigued lately. And then I also wonder, is it seasonal affective disorder? Like, you're always trying to figure it out. I'm sure there's listeners feeling the same way. How do I know which things these all are, and who do I talk to first? What would you say?
Yeah, that is so not an easy answer because every one of us is different. In other words, if you already have seasonal affective disorder or you have underlying depression, yes, the hormonal chaos or roller coasterness of perimenopause may be impacting a worsening, but it also may be you're taking extra courses in your graduate work, or you're having money troubles you didn't anticipate, or your mother-in-law has moved in. It could be so many things like that. So obviously take a good look in the mirror and ask yourself if you can try to pinpoint something. And obviously if you need help from a trained behavioral health therapist, and we already have one or don't, you should address that and say, hey, I'm concerned. Things are getting crazy and it could be this, but I want to tell you about what's going on and get your opinion. But there's nothing wrong with going to a gynecologist or even your primary care physician and saying, I'm concerned that there could be a hormonal impact to my life where it's not just that my periods are irregular. I am honestly experiencing fatigue. I cannot get out of bed in the morning, and that's not me. I'm stress eating, and that's not me at all. I'm not sleeping right. We need steady, predictable estrogen and progesterone secretion for so many things, for the brain, for sleep, for happiness. So the impact can be quite broad. And sadly, as I mentioned, a lot of physicians, we get so trained in our own little sliver of medicine, we don't think more broadly. I've had patients come with palpitations because guess what? There are estrogen receptors on the part of the heart that governs the rhythm of the heart. Sure enough, their doctor said, oh, you just must have anxiety. You need an antidepressant or an anti-anxiety. And it didn't help. And the woman came into me saying, my primary care thinks I'm just crazy, and I'm not crazy. I'm really having these palpitations. We put her on a little bit of estrogen. They were gone immediately. It was like we took a dry erase board. And that's not going to happen to everyone.
Right.
But it's really important to think for yourself a little outside the box and remember those teeny little ovaries can have very powerful effects.
Absolutely. I have to ask, is there anything that they can do before they do this? I know there's a lot of companies popping up where you can send in blood or whatever to get tested on different things. Do you know much about that?
Yeah, there is a bit of a money bonanza going on right now. So people are saying, oh, there's this big interest in menopause and perimenopause. And that is great. I'm thrilled about that. I want you and all your listeners to be perimenopause aware, menopause aware, health aware. But I don't want you to fall prey to Instagram offers to take your blood and tell you whether you have too much or too little estrogen. That's not what you need. In fact, we use those levels very little. What we need is to be good listeners. A good clinician is going to listen and going to figure out if what you're saying links to possible perimenopausal symptoms or hormone related symptoms. Drawing blood, we do sometimes. We certainly check it for thyroid and things like that. But since in perimenopause, your estrogen goes like this, up and down, if I draw it on Tuesday, it might be very high, and on Friday, very low. So, Kendra, do you have a lot of estrogen or a little estrogen? Nobody should tell you, you're estrogen dominant. You're not. That's not a thing. That's not a medical thing. And anyone who says those terms doesn't understand that up and down chaos, that stick shift car going uphill in your mid 30s to late 40s. So values of hormones are unimportant, and nobody should be selling you supplements or medications based on those values for sure in perimenopause. Once you're menopausal, no periods for 12 months, especially if someone has drawn your blood and shown that your FSH, follicle stimulating hormone, is high. That's in the brain. That's the brain yelling louder and louder to the ovary, hey, send me some estrogen. That goes high when you're in menopause and stays high the rest of your life. If yours is high, you are menopausal. And yes, you would benefit tremendously, like most women do, from replacing some of that estrogen, progesterone, testosterone, depending on whether you have a uterus. If you have no uterus, you don't need the progesterone part. Interesting, right? If you have a uterus, you must have progesterone because estrogen alone will cause tissue to grow in the uterus. And we don't need you to do that in menopause. It could be dangerous. So if you're menopausal and you have a uterus, anyone giving you estrogen could also be giving you progesterone. But your question was about blood work, I think. And blood work's super helpful to rule out autoimmune diseases, thyroid, stuff like that. But a lot of people are making a lot of money saying, we'll draw all your hormone levels. Be very careful about that. It's very rare that you need, quote, all your hormone levels drawn, and they're expensive. And usually they get a kickback, like money. It's their lab or they get money. And so that's not cool. That's not good ethics.
Okay. Good to know for that. I love the feedback.
Yeah.
Also, though, I know there's fear for so many people to be taking too much medication, or in the past there's been a lot of talk about how being on hormones too long can increase your chances of certain types of cancer. So what if there's this fear of taking any of these hormones?
Yeah, absolutely. That fear is widespread, and that fear is 23 years old. So we've been fed incorrect information for 23 years, since 2002, actually 24 years now, right? Yeah. And that came from a study called the Women's Health Initiative that, unfortunately, that study was made with the best intentions to look to see if hormone use helped or hurt the development of heart disease. But they checked women who were in their 50s, 60s, and 70s. They had them on a synthetic oral estrogen that we really don't use anymore. Oral estrogens can increase clotability of the blood, so increase risk for heart attack or stroke. So sure enough, there were some negative effects in that study, and even some women who got breast cancer. All women have the risk of getting breast cancer. Anyone with a breast does. So if you do any study and it's big enough, there will be some women who get breast cancer. That doesn't mean the medication caused the breast cancer. But the people who did the study shut the study down early and made a very public announcement saying, we think estrogen causes breast cancer. This was a disastrous thing, a terrible thing they did. This caused global panic. People stopped using HRT. Doctors stopped prescribing it. And the link between hormones and cancer was put in cement like crazy glue. And it's been very hard for those of us who know differently to undo that. The data has been relooked at from that study. It was unfortunately misinterpreted. If I throw a basketball hoop at a net to make a point, it bangs on the rim and then falls on the floor. I don't get those 2 points. Same with statistical analysis. When you do a study, it has to be significant enough to be called statistically significant. Those couple cases of breast cancer were not statistically significant, but the people didn't mention that. They just made the link, and the public linked it, and the damage was done. Now what we know is exactly the opposite, actually, that women who use hormone therapy, especially in the first 10 years after menopause, have about a 30% lower risk of breast cancer. That's mic drop moment, right? They also have about a 40% lower incidence of colon cancer. They have later onset dementia. They have less heart attack, lower stroke risk. So all this great news, but it got overshadowed by the bad news that was inaccurate. So it's really important, Kendra, that people like you and I help clarify that for our patients, because patients still come see me every day and say, oh, I'm suffering terribly with hot flashes. I would give anything to go on hormones. I just don't want to die of breast cancer. And I say, I don't want to die of breast cancer either. But the first statement and the second, not linked. You needing HRT and not wanting to die of breast cancer are not related, does not cause it. So that's really important, I think, because if women can unhook that fear, then they can look objectively and say, why do we use HRT? And the answer is 2. Number 1, to help symptoms. Okay. I have hot flashes. I have brain fog. My skin is dry. My vagina is dry. Sex is painful. I'm getting urinary tract infections. 100 reasons, right? Number 2 is called preservation of function, meaning I want to keep these hormones in my body, which have been in my body, by the way, since I was a fetus in my mom's womb and served me well, right? If estrogen causes breast cancer, then why don't all women get breast cancer in pregnancy when estrogen levels go really high? Why isn't there a spike in breast cancer at puberty when everyone's estrogen level goes up? Like that, it doesn't make sense. It just doesn't make sense. Why is it we get breast cancer more as we age when we don't have estrogen? Riddle me that one, right? It actually doesn't make sense. So preservation of function is the second reason, and that's because estrogen receptors are in the bone. And we know that as soon as you go through menopause, you have the most rapid loss of bone strength in your whole life. So in those first 5 to 10 years after menopause, so say age 50 to 60, that's when women lose the most bone strength and set themselves up for osteoporosis. So if you can be taking estrogen in those 10 years, you delay or prevent osteoporosis as an older woman. Ditto for heart disease. Women have lower heart disease from age 0 till, shocker, 50. And then around 50, it starts to close the gap and approach the risk of heart disease that men have, because men don't have the protective effect of estrogen. And by 60, women's risk of heart disease, they've been without estrogen so long it actually passes that of men. So I think the preservation of function, of heart function, of brain function, skin function, we lose 30% of all the collagen in our skin gets lost in the first 5 years after we're menopausal. So for people like me who really don't want to look older and faster, it's do it for that. Lots of reasons. Okay. Preservation of function and symptoms. Those are really the two reasons one might consider that.
Very helpful to know, especially for those of us that aren't quite in that stage yet.
Looking ahead.
Thanks for joining us today for this powerful start to our conversation with Dr. Sophocles. If you're craving more tools for reclaiming calm and fulfillment through life's transitions, visit fulfillmenttherapy.org to explore our community group coaching and self-paced online courses. Or email us at hello@fulfillmenttherapy.org to suggest a topic you'd love to hear next. We'll see you back here shortly for part 2. Hey friends, if you enjoyed this episode, a quick 30-second share can help someone else find support and help this podcast grow. Leaving a review on Apple Podcasts boosts visibility and keeps the show alive. Your simple acts make a big difference. I'll see you back here each week for more life-changing episodes.